So, for the pathogenesis of birth asphyxia, you need to know that what when you want to understand how the causes result to birth asphyxia, there are two major mechanisms how the cause can result to birth asphyxia. The first mechanism via which the cause can result to birth asphyxia is via acute fetal distress mechanism. And the second mechanism via which the cause can result to birth asphyxia is via fetal abnormalities. Abnormalities. Now, these are the two major mechanisms via which you can speak about that. Now, under acute fetal distress, you have now to speak about the etiologies of acute fetal distress, and you have to speak about the etiologies of fetal abnormalities resulting to birth asphyxia. So now let's start with acute fetal distress. When you want to speak about etiology of acute fetal distress, you need to know that these etiologies are divided into three. The first one, you're going to have pre-placental, you are going to have placental, and you are going to have post-placental. So those are the three major ones in acute fetal distress. You're going to have pre-placental, you have placental, and you have post-placental element. Now, under pre-placenta is anything that is going to reduce, any pathology that reduces perfusion of the placenta. Any pathology that reduces perfusion of the placenta is associated with pre-placental causes of acute fetal distress. Now, placenta is any pathology directly affecting the placenta is associated with the placental acute fetal distress, and post-placental is associated anything that is going to affect the umbilical cord is mostly at the post-placental elements of acute fetal distress. Now, let's start with the pre-placental. So under the pre-placenta, what are the etiologies of which are under pre-placenta? The etiologies, when you want to split the etiologies here, it is better to put etiologies divided into obstetrics etiology and non-obstetrics etiology that can reduce perfusion to the placenta. For the obstetric etiology, we have the hypotension of the decubitus. Decubitus. So decubitus hypotension, meaning that what generally this is the cause why you are going to have acute fetal distress when a woman is going to lie on her back. If a woman lies on her back, that's in the decubitus position, the child is going to have acute fetal distress because there is going to be compression of the inferior venous cava, which is going to reduce the venous return and reduce the cardiac output. So in order to prevent that, you need to the patient has to lie on the left lateral decubitus. The left lateral decubitus is preferred to the right lateral decubitus, though there is not too much difference, because in the left lateral decubitus is going to be compression of the aorta, but you have to know that what the aorta is going to be thick. The aorta has thick artery, thick walls, so the compression of the aorta is going to be least, and the pressure also of the heart is going to overcome that compression. So there is also pressure inside the aorta, but sleeping on the right decubitus, you may compress also the inferior vena cava, and the inferior vena cava has thin wall, and the pressure is approximately 0 millimeters of mercury. That's why the left lateral decubitus is more preferred to the right lateral decubitus, though there is no much clinical significance. So the lateral decubitus position is preferred much more than the dorsal decubitus position. So that is the obstetric problem that is associated with the pre-placental. Is it clear? Now we have other obstetric abnormalities like preeclampsia. Preeclampsia can also be associated. Eclampsia can also be associated among the etiologies under pre-placental. The pre-placental etiologies here. Now the non-obstetric is any other disease that may result to hypoperfusion inside the uterus. So you may have uterine malformations. You may have a chronic heart failure. You may have a chronic liver failure. You may have a chronic renal failure, and you have a COPD that is going to result to hypoxemias and all that. So all that are going to be associated with pre-placental etiologies of acute fetal distress. Now, the next one is going to be associated is the placental etiologies of acute fetal distress. Now, for the placental etiologies of acute fetal distress, you need to say that what the element you have the etiologies here. The first etiology here, you're going to have the placenta previa. You're going to have the second etiology, which is placenta abruptio, placenta previa, placenta abruptio, and we have the third etiology, which is the uteroplacental insufficiency. Is it clear? And you need to know that, as we are going to see under the obstetric tutorial, placenta previa generally present with a painless bleeding, while placenta abruptio generally present with a painful bleeding. Is it clear? And in placenta previa, the uterus may contract, so generally it's not associated with labor. While in placenta abruptio, there is a typical contraction. The uterus is going to be bulky in the cases of the placenta abruptio, and there may be an increase in the sensitivity of under height. But why? Because there is going to be accumulation of the hematoma. If there is a concealed placental abruptio, there is going to be accumulation of blood. Is it clear? That is going to produce a hematoma, and that hematoma may prevent the uterus from contracting. And the next thing is that the blood in placenta abruptio is much more darkened because it is hematoma that is released and it is clotted, while the blood in placenta previa is much more bright red because it's directly lost. Is it clear? And then in the case of the uteroplacental insufficiency, you have to know that it is mostly as a result of placental insufficiency, mostly as a result of postterm. If you have postterm children, is it clear? There is going to be reduction of the perfusion of the placenta. Is it clear? That in the case of uteroplacental insufficiency, another cause of uteroplacental insufficiency can occur still as a result of preeclampsia. Is it clear? Preeclampsia may result to a disruption of the blood vessels there, and it's going to result to a uteroplacental insufficiency. Another element of uteroplacental insufficiency are infectious diseases. Is it clear? You have late infectious diseases like malaria. Is it clear? Late infectious disease like malaria, which is going to accumulate at the level of the placenta, resulting to reduced perfusion of the placenta. And we have early infectious diseases like the torches infection. Is it clear? Like the torches infection that you have to understand here. Now, the next etiology are going to be the post-placental etiology. Is it clear? The post-placental etiology are usually associated with the umbilical cord. Is it clear? And in the case of post-placental etiologies, you need to know that when you have umbilical knot is an example. Is it clear? You are going to have vasa previa. Now, vasa previa, you need to know that it is loss of the fetal blood as a result of the insertion of the umbilical cord at the level of the lower uterine segment. When there is insertion of the umbilical cord at the level of the lower uterine segment, is going to when there is cervical dilation, there is going to be bleeding from that inserted point. Is it clear? And when it is bleeding like that, you are going to have loss of the fetal blood. Only about 100 mils. If you just have a 100 mils loss of the fetal blood, generally it's going to be fatal. It's just a small loss like 100 mils of fetal blood of that blood may result to a fetal distress and a fatal death. Is it clear? Now, the next element, we have nuchal cord. Is it clear? When you have a cord around the neck of the child. So those are the different elements which are associated with the acute fetal distress. Now,